Just Hard Podcast, Fluids and Electrolytes, and Infusion Therapy, the IV Fluid Games. May the osmolality be ever in your favor.
Welcome back to Just Hard, real nurses, real talk, real life. I'm Chelsea Justice.
And I'm Lisa Harding. We also have our special guest returning, DJ Chewy. He will be a nursing student and helping us with our unsponsored commercials. Thank you, Jesus, for joining us today.
Thank you for having me.
Today, we're diving deep into something that will literally save your butt on the floor and on NCLEX.
Fluids, electrolytes, and infusion therapy, also known as why is my patient puffy and can I really run that through a peripheral IV?
And my personal favorite, wait, why are we giving albumin and Lasix?
At least the nurse questioned it. That's half the battle, knowing when something doesn't seem right.
No kidding. Okay, so this material is for any students out there, and honestly, even if you've been a nurse for years, this one is one of those topics that you need to understand on a cellular level, pun intended.
But before we jump in, we have a very important message. In a world where fluid balance hangs in the balance,
where one wrong IV solution could tip the scales,
there exists a choice, a decision, a crossroads of isotonic, hypotonic, and hypertonic proportions.
Today's episode is Fluids and Electrolytes, the ultimate IV challenge.
Watch as nurses everywhere must choose between normal saline lactated ringers and D5W,
while dodging questions from attendings, navigating policy changes, and avoiding that one coworker who always says, well, actually...
Rated PG-13 for intense IV catheter insertions, mild language when the pump alarm won't shut up, and one terrifying scene involving an unlabeled bag of clear fluid.
Okay, but seriously, can we talk about how people actually do try to run potassium through a peripheral line at like 48 milliequivalents an hour?
Oh, we'll get to that. Let's get started.
All right. So, let's start with the basics. Your body's basically a fancy water balloon, right?
I mean, yes, we're like 60% water, and that water has to go somewhere. So we divide it into compartments.
We've got intracellular fluid. That's fluid inside your cells. That's about 70% of your total body water.
And then we have extracellular fluid, which is everything outside of the cells. That's the remaining 30%, and it actually breaks down further into two spaces. Interstitial, meaning between, inter, meaning between, and intravascular, meaning within, so within the vasculature.
Interstitial fluid, that's the fluid happening between your cells, like in the tissues. That's about 22% of your total body water.
And then the intravascular is inside of your blood vessels. Only about 6% of the total body water, but that's super, super important. And that's one of the things I like to think about when we talk about infusion therapy. We're actually cannulating a vein and infusing it into the vasculature. So that's very important.
Yeah, here's the thing students need to know and nurses need to know. The total solute concentration in the intracellular and extracellular spaces is similar. They're balanced.
But the specific electrolytes in each compartment are totally different.
So
I think most of our students at this point know potassium is your primary intracellular, loves to hang out inside the cells, while sodium prefers the extracellular space.
Exactly. And this is going to be super important when we talk about how fluids move and why we give certain IV fluids. So let's talk about how those fluids move.
Right. So now that we know where the fluid is, there's four main mechanisms of how that fluid moves throughout the body: osmosis, diffusion, filtration, and active transport.
Let's start with osmosis. This is water movement.
Right. So with osmosis, it's the water that moves. Water moves across a semi-permeable membrane from an area of lower concentration to an area of higher concentration.
Think about it like this. If you have super salty solution in one side of a membrane, water is going to move towards that salt to try to dilute it and reach equilibrium.
The body is always trying to achieve balance. It's very zen like that.
Next up, diffusion. This is when solutes move, not water, but the dissolved substances themselves.
So kind of the opposite a little bit. So solutes move from higher concentration to lower concentration, kind of like if you're dropping a tea bag into hot water.
Yeah, those tea particles diffuse from the concentrated tea bag into water until it's evenly distributed.
And this part could happen with or without a membrane present.
Okay, now filtration. This is any process where particles are separated from fluid by passing through a filter or a membrane.
So the driving force could be gravity, pressure, or concentration gradient. You can think about this like making coffee.
Drip coffee is gravity-driven filtration. French press is pressure-driven filtration. And instant coffee is concentration gradient filtration.
I love how we're using coffee examples for everything. That was very in-depth coffee example, actually.
I know. Coffee
Future
is life.
barista there.
I know. Coffee is life. Yeah. Because nurses run on coffee. Okay, so last one, active transport.
This is when you have to move ions from a low concentration to a high concentration. So you're going against osmosis and diffusion.
It's like paddling upstream. You need energy for this, specifically ATP.
Right. Classic examples, a sodium-potassium pump uses energy to pump sodium out of the cells and potassium into the cells, maintaining those concentration gradients we talked about earlier. Also important to note, ATP, the P stands for phosphorus. If your patient's phosphorus is low, they can't make adequate ATP. And they're going to be super, super weak and super tired. Try getting a patient off of a vent with no phos.
I know, like that's the
Not gonna
ICU
happen.
nurse. Yeah, that's ICU nurse in you coming in. But yeah, I mean, I think we are so used to looking at potassium levels on the labs. We look at sodium, but we often like neglect phosphorus unless our patient is a renal patient.
Why isn't phosphorus part of the BMP?
I don't know. We should let's start a petition.
I know. Phosphorus and magnesium should be part of the BMP.
I get it. We should just add it.
Yeah, I think so.
They should listen to us. We're smart. Yep. Okay, let's talk about capillary equilibrium. So this part is critical and it's crucial for understanding edema. We need to talk about capillary equilibrium.
So at the capillary level, we have two forces at work: hydrostatic pressure and oncotic pressure.
Hydrostatic pressure is the push force. It's generated by the heart pumping blood, and it pushes fluid out of the capillaries into the interstitial space.
And then you have oncotic pressure. This is the pull force. It's mainly created by plasma proteins like albumin, and it pulls fluid into capillaries from the interstitial space.
This is called reabsorption.
So on the arterial side of the capillary bed, hydrostatic pressure is higher, so fluid gets pushed out to deliver oxygen and nutrients into tissues.
And on the venous side, oncotic pressure dominates, pulling fluid back into the capillaries.
So when these forces are balanced, you have normal fluid distribution. And when they're not,
you get edema.
I promise this is something that you guys actually have to know and understand. It seems kind of dry right now, but when we get into the fluids,
yeah,
it's essential.
Pushing, pulling, why is it happening, and what is actually happening with the meds we're giving? Definitely an important thing.
All right, let's have a quick commercial break.
Okay. Do you find yourself stress eating an entire family-sized bag of chips after a 12-hour shift?
Does your Fitbit think you've run a marathon when you've really just been running from room 12 to the med room 47 times?
Introducing Nurse Fuel, the energy bar specifically designed for healthcare heroes.
Disclaimer, Nurse Fuel is a fictional product. Any resemblance to actual energy bars, living or dead, is purely coincidental.
Please do not attempt to create Nurse Fuel at home. Side effects may include actually having energy during the night shift, which could alarm your coworkers.
Each bar contains caffeine equivalent to 3 espressos, enough protein to build your glutes for when you bend down to empty that Foley bag, and a proprietary blend of Let's Do This.
Available in 3 flavors: Charting After Midnight Chocolate, Code Brown Caramel, and Why Did I Become a Nurse Berry Blast.
No actual nurses were harmed in the making of this fake commercial, but several were emotionally damaged by real 12-hour shifts.
Nurse Fuel.
Because self-care is just a fancy word for...
I survived another shift without crying in the supply closet.
Nurse Fuel.
Okay. Thank you for that unsponsored commercial. All right. So let's talk about body fluid regulation. So your body has some pretty amazing mechanisms to regulate fluid balance. Let's break them down.
So first there's thirst, simple but effective. When you're dehydrated, your body tells you to drink water.
Then you've got your kidneys, which are basically the bouncers of your body, deciding what stays and what goes.
And then we have RAAS and ADH.
Let's start with the RAAS, the renin-angiotensin-aldosterone system, RAAS. This gets activated when you have a decreased renal perfusion or decreased glomerular filtration rate.
When I was in anatomy and physiology, I thought I would memorize the Krebs cycle and the RAAS and then dump it and never have to look at it again.
Every
and it
day.
Always comes back.
Every day.
Yep.
Every day. Yes.
So RAAS, renin-angiotensin-aldosterone system. So basically when your kidneys aren't getting enough blood flow, they freak out and release renin.
Renin converts to angiotensinogen to let me rephrase this. Renin converts angiotensinogen to angiotensin 1, which then gets converted to angiotensin 2 in the lungs. Think about if you have lung damage. Is that activation going to actually happen?
Angiotensin 2 makes the adrenal cortex secrete aldosterone, which tells the kidneys to hold on to sodium and water and dump potassium and hydrogen ions.
So the end result is increased blood volume because we're holding on to the water and the ions, and it increases the blood pressure because we have increased volume.
Right. So, and this is going to come back when we talk about heart failure. So now ADH is antidiuretic hormone. That's something that gets released when you have low blood pressure, low blood volume, or high osmo.
So osmoreceptors in the hypothalamus detect these changes and tell the posterior pituitary to release antidiuretic hormone or ADH.
And then ADH increases the permeability of the distal tubules, so you reabsorb more water. So less urine output, increased blood pressure and volume, and decreased blood osmolality.
Because I'm holding on to all that water.
Have we completely lost you, Jesus, as our nursing student here?
You know what? It's all coming back to me now from A&P. So now
Yep, you never you didn't get to dump it.
No.
Yeah.
So it's all coming back, and this is a really good refresher for me. So I'm just glad to have a front row seat.
Yeah, we're glad you're here.
Perfect. All right. Well, we are going to ask you an NCLEX question, Jesus. Are you ready?
All right, let's do it.
Okay. A patient with heart failure has been admitted with shortness of breath and 3+ pitting edema. The nurse understands that the edema is most likely caused by A, increased hydrostatic pressure, B, decreased oncotic pressure, C, increased capillary permeability, or D, lymphatic obstruction.
Well, just based on the answers and they're already having edema, I'm going to go with A, increased hydrostatic pressure.
Yes.
Take that.
Your A&P instructor would be so proud of you. Yes.
Yes. So increased hydrostatic pressure is correct.
Great. Yeah. In heart failure, the heart can't pump effectively, so blood backs up into the venous system, and this increases the pressure in the capillaries. That's your hydrostatic pressure, which pushes more fluid out into the interstitial spaces.
And that's why we make students learn this. And that is what causes the pitting edema. The fluid is literally being squeezed out of the vessels because of that backup pressure.
Yeah, now you might see decreased oncotic pressure in liver failure when albumin production drops, or increased capillary permeability in sepsis or burns, and lymphatic obstruction would give you more of a localized non-pitting edema.
So always answer what the question is asking you. So heart failure, shortness of breath, pitting edema, it's caused by increased hydrostatic pressure from a faulty pump.
Yeah, great. All right, let's talk about volume status. When things go wrong with fluid balance, you have too little fluid or too much fluid.
So let's start with a fluid volume deficit. Now things are going to start getting fun.
Yeah.
This breaks down into two types.
Hypovolemia is when you lose both water and electrolytes from the extracellular fluid.
So think about hemorrhage, vomiting, diarrhea, burns. You can lose whole fluid, not just the water.
Yeah, then there's dehydration, which is a loss of water without losing electrolytes.
So if someone has a high fever and they're sweating profusely, or they've been vomiting repeatedly and only losing stomach contents, mostly water and some electrolytes, but proportionately more water loss.
And remember, older adults and pediatric patients are at great risk for fluid volume deficit, fluid loss.
Why is that?
Well, because they have a difficult time regulating their volumes.
And decreased subcutaneous tissue.
Absolutely.
For older adults, right?
Yep.
That would be one of our age-related changes.
Yeah. We talk about that thin skin problem that we have.
Yep. And regulating their body temperature too.
Mm-hmm.
Kids and older adults are always at greater risk for some type of complications, it seems like.
Yeah.
All right. So fluid volume deficit. Okay. On the flip side, you have fluid volume excess. So let's talk about that.
Yeah, so hypervolemia is isotonic retention of water and sodium. Think heart failure, kidney disease, liver cirrhosis.
And then overhydration is a hypoosmolar gain of more water than electrolytes. So hemodilution.
Yeah, like SIADH, or the syndrome of ineffective antidiuretic hormone, where you're retaining too much water relative to sodium.
Right. So Edema. So here's a question that I love to ask students. So, Jesus, what do you think? If your patient has edema, does that automatically mean that they're fluid overloaded?
I'm just gonna say, not they have too much fluid and it's got nowhere else to go. So I'm gonna say yes.
Yeah, I mean, your thought process is on point there. So if we see edema in a patient, it tells us externally that there's too much fluid, but it doesn't tell us intravascularly where all that fluid is. So sometimes a patient can be like super puffy, but dehydrated intravascularly.
I know, it's kind of a trick question.
It's a total trick question. And it really challenges you as a nurse to really try to understand what's actually happening. Why we automatically assume that the patient is fluid overloaded. So thanks for answering that because, well, plus we told you to answer it that way. But
Well, I have a story.
Yeah.
One of my as a CNA, I had a patient that I didn't know like what it was going on with him, but obviously he was just really puffy, and I was always having to change his linen because his bed would be soaked, and I thought it was just he was sweating a lot. But then come to find out, no, that's one of the nurses on that shift was saying, no, this is edema. And so if the fluid has nowhere to go, it's just going to seep out of his body. And that was my first introduction to what edema was.
yeah, I love it.
That's a good story. And that would be what we call weeping edema, where it's so significant and it's just oozing out of the skin. You're changing the chucks.
Yeah.
Yep.
So the poor little kidneys are probably like, I want all that fluid, and it's leaking out into the tissues. And the kidney's like, don't throw that away. I want that.
And I was just like, oh, and this guy was, I was having to do a lot of the muscle and the moving him to rotate the linen. And it was just, my mind was just wondering, like, why is this happening again? I was, again, brand new CNA, and this was a whole new open world to me where I
love that.
Getting exposed to different things. But that was for sure what stood out to me. Like, I'll never forget what actual edema looks like.
That's
and
why
was
you're such a
prime
good
example.
nurse, because you're thinking about the why way back then.
Right.
Way back then. It's not just a task. It's a why. Why is this happening? I love that.
So edema just means like your fluid balance is disrupted and you have some accumulation in the interstitial space.
It can be localized or generalized, and it can result from three main problems.
1, increased hydrostatic pressure, like in heart failure with a faulty pump.
2, decreased oncotic pressure, like in liver failure where you're not making enough albumin.
Or 3, increased capillary permeability, like from inflammation or injury.
Now let's talk about the two types of edema, pitting and non-pitting.
So pitting edema is usually from fluid overload or circulatory issues. So when you press on it, you leave an indentation because that fluid is mobile.
Yeah, common causes here are heart failure, liver disease, a DVT, kidney disease, or just standing for too long, like being a nurse that works a 12-hour shift. Sometimes I even see this, like the Foley tube that's laying on the top of their leg. You can see a little indentation from that. Yeah. I mean, not that we use a lot of Foleys anymore.
Yeah,
Hello,
we're
PureWick.
lucky if we get one.
The PureWick tube.
The PureWick tube. Sometimes we get a Foley, which is nice.
You do.
Well, it's
Miss
even,
ICU
it's
nurse.
even hard in the ICU to get a Foley. So we grade pitting edema from 1+ to 4+ based on how deep the pit is. So 1+ is less than 1/4 of an inch, and 4+ is greater than an inch deep.
Yeah, and this is so important that we understand everything we do in nursing is measurable. Our documentation is measurable. How do you know if your patient is getting better if you just chart edema? You have to use that score. So also, non-pitting edema doesn't leave an indentation when you press on it or leave the Foley.
And that's usually from lymphatic obstruction, inflammation, or conditions that cause tissue changes.
Yeah, the fluid gets trapped in the tissues with proteins, cells, and fibrotic materials, so it's less mobile. Think lymphedema or myxedema, which we'll talk about when we talk about thyroid.
Yes, I do have one quick thing that I want to say about lymphedema because I recently encountered it. I had a patient who their left arm was more edematous than the right. So all the nurses are thinking like DVT, right? They're all thinking DVT. Well, I went and I did her bath. She was missing her left breast. I'm like, she's had a mastectomy.
Hello, terrible assessment.
Right?
Why do people not look at your whole freaking patient?
Yeah. Well, the patient had like no breast tissue anyways. So I thought that the telly sticker was on her nipple. Oh. So when I did the bath, I was like, well, let me put that somewhere else. And there was the fine scar. And I was like, oh my God, she's had a mastectomy.
Good for you for noticing that. The other nurses should be slapped.
And then we did the limb alert and everything. But I'm like, this is lymphedema because we've been doing all the blood pressures and IV draws on this arm and nobody noticed that. And that's so bad.
Yeah. Yeah. Do a complete head to toe. You learn
Yeah.
that the first day of nursing
Right?
school.
Yeah, there's a reason that we do our assessments.
Duh.
Don't trust another nurse. Always do your own assessment.
Right.
So that's my lymphedema story.
I love it. I love it.
All right, let's have another commercial break.
Definitely.
Hello, fellow bedside warriors. Are your legs screaming at you after hour 8 of your shift?
Do your ankles look like they belong to someone else by the end of the day?
Are you tired of that cankle life?
Then you need Nurse Legs Pro Compression Socks.
Disclaimer, this is a fictional product. Any resemblance to actual compression sock brands is purely coincidental.
Finally, compression socks designed by nurses for nurses. With graduated compression from 15 to 20 millimeters of mercury, these babies keep your circulation moving when you've been on your feet for 13 hours straight.
Not only do they keep you comfortable, but they help prevent varicose veins from all that standing.
Because let's be real, we're already dealing with enough vascular issues with our patients. We don't need our own legs betraying us too.
They're moisture-wicking, antimicrobial, and durable enough to survive multiple trips through the laundry when you've stepped in, well, you know.
Nurse Legs Pro Compression Socks. Because your legs deserve better than whatever's happening to them right now.
Side effects may include actually making it to your car without limping, reduced ankle swelling, prevention of varicose veins, and the ability to stand through one more admission at the end of your shift.
Warning, may cause extreme comfort. Do not operate heavy machinery or make life-altering decisions while wearing Nurse Legs Pro Compression Socks, as you may feel too good and forget why you were complaining in the first place. Nurse Legs.
Squeeze the day. I actually do wear my compression socks every day.
As do I.
Yep.
As do
and
I.
I have different brands that I found because there's some that are so tight.
Yeah, that's not good.
Yeah, I have like the mid-grade ones. I wear them every day, and I feel different. Like if I don't wear them one day at the end of my 12-hour shift, I can feel a difference.
Yeah,
and
I
then
do too.
do you ever have some, like I have some with like designs on them, like
Oh, yeah.
flowers, and you take it off and you have the flowers on your leg?
Yes. You're like, yes.
Yep.
I'm looking
So
good today.
They actually work.
I wear them every day. I worked
Yep.
yesterday, and it
I
was
did too.
it was a terrible.
Did I work? Oh yeah, I did too.
It was a terrible day for no breaks. I mean, like no pee, no water, no break, no nothing. It was a long day standing on my feet, and I came home and I was like, I'm dying, and it hurt so bad. And I had my compression socks on,
Yep.
so yeah, some days it just doesn't work.
Yep. They make a difference.
Yes.
All right, let's talk a little bit about third spacing.
Oh yeah.
So
it's a good one.
third spacing is when the intravascular and interstitial fluids accumulate in a body space where they shouldn't be. So basically like edema on steroids.
Yeah, that fluid is just sitting there, being non-functional. It's participating in normal physiologic process. It's not. Yeah.
Right. Yeah. So it's just there in the way, taking up space, doing us no good.
Yeah, except for waiting to get infected.
Yes.
Yeah.
Yep. See, your IR is coming out
Exactly.
there. Yeah. So classic example, ascites in the peritoneal cavity, pleural effusions in the pleural space, or a pericardial effusion around the heart.
And it's tricky because the patient might look like they have plenty of fluid, but they could actually be intravascularly depleted, like we just talked about.
Yeah, like Jesus' patient with the weeping edema, they could have been intravascularly depleted. So all that fluid is trapped, useless. The patient might need fluid resuscitation. So Jesus, what type of fluid might we use for that?
Well, I'm going to say I'm taking a shot in the dark at lactated ringers.
Yeah?
Yeah, lactated ringer is great volume.
I'm not going to lie. I totally, off the top of my head.
See, nursing students, trust your gut instinct.
That's right. Yeah, memory molecules to the rescue.
Yeah,
Whoop, whoop.
so
Yeah.
lactated ringers is isotonic. It would hydrate we would put that fluid into the vascular space, and it should stay in the vascular space.
Yeah, and then so another thing that we do, like I actually love talking about this. So the albumin and Lasix combination. Yes.
So many nurses don't understand this.
like,
This is
use
a great
your
topic.
brain.
And
Yes.
it works.
Yes, it is. It's so great. Yeah. So albumin, if we give a patient synthetic albumin in a little bottle first challenge is if you have an option to grab a bottle or a bag, grab the bag. Because the bottle never flows very well, and you got to jerry-rig that
Yeah,
sucker.
there's tricks, but I don't know if we want to talk
no,
about those yet.
because those are not sanctioned by Joint Commission. Right. Anyhow, so save yourself. If you have a bottle or a bag, choose the bag, number one. Number two, give your albumin and look peak onset and duration. Why did you have to memorize those in nursing school? Because they matter. So how long does it take for albumin to pull the fluid from the interstitial space into the intravascular space? You need to know that. So give your albumin, wait 30 minutes or so, depending on how much you give and what the extent of the edema is, and then give your Lasix. Do not give them both at the same time. A pharmacist sitting behind a computer or AI or some generated something that doesn't have a brain. Not that pharmacists don't have a brain, but sometimes I question it.
Oh.
Anyhow, they're just randomly saying, oh, it's daily, let's give it at 9 o'clock. No, use your brain. Give your albumin first, let it work. Once you pull all that fluid into the intravascular space, your patient might become more symptomatic. Then give your Lasix. Let it work. Because if you give Lasix to a dry vessel, then give your albumin, the Lasix has nothing to pull.
Yeah, there's no point.
There's nothing.
Yeah.
You're pissing in the wind.
Yeah, exactly.
So don't piss in the wind.
Yep. Now, if I go to like a rapid response and the patient is drowning in their own fluids, I might give that Lasix right away.
Absolutely.
But if we're just given the time and the acuity of the situation, like we are going to want to give the albumin and then the diuretic.
Yeah. The point
Always
is
given
the
time.
fluid is in the wrong place. You
Right.
need it in the vessel for Lasix to work.
Yep. So you can be fluid overload. You can be net positive. You could be net positive 5-10 liters of fluid
Yes.
and intravascularly
Dry.
depleted.
Yes. 100%. Yeah. Okay.
Yeah.
And here's another thought-provoking question. So you can email me if you know this answer, because I've asked nephrologists and they struggle with this one. Think about Lasix. How does Lasix work? Where does Lasix work?
In the loop of Henle.
Yes, and that's in the kidney, right? So if your patient has a GFR of 0, meaning the glomerular filtration rate is 0, it's not working, it's not filtering, which means your loop of Henle are died, checked out, not working, on break permanently. Why are we giving these people Lasix?
Okay, I get confused about this too sometimes because I've asked nephrologists also, like when we have somebody who isn't making urine and then they're like, well, let's give them Lasix or Bumex and see if it stimulates. I've never really understood it.
It makes no sense.
No.
Yeah,
it doesn't.
your kidneys are broken, so we're giving them medication. No, so if you have some kidney function and you make some urine, maybe that's effective.
Mm-hmm.
But if you're anuric and you
Why?
have no kidney function, you're on dialysis, how is that going to help?
It's not.
It's not.
It's not.
Thank you.
Yeah. Just like nurses, these are the reasons that we lose our Foleys because people don't think. Don't put a Foley catheter in an end-stage renal patient.
With
it doesn't matter
angina,
anymore.
right?
Yeah,
Yeah.
that's why we lose our Foley privileges because then they get infected and then we
Yeah.
don't get them when we need them and your patient's on 3 pressors and they tell you to use a PureWick.
Exactly. Yes, exactly. Okay, rant over.
All right.
This is a good time for a commercial break, I think.
All right, let's do it.
Okay. Welcome to Guess That Lab Value, the game show where the answers never make sense and your patient is always in denial.
Our first contestant is Mrs. Davis, who's convinced her sodium is low because she, quote, doesn't salt anything.
Hello, I'm Ms. Davis, and I'm very concerned about my sodium. I read on Facebook that salt is poison, so I stopped using it completely. My sodium is low, isn't it? I can feel it.
Wrong, Mrs. Davis. Your sodium is 152. You're hypernatremic, not hypo.
But how? I haven't touched salt in months.
That's not how bodies work, Mrs. Davis. Thank you for playing.
Ding, ding, ding. And now, spinning the wheel of chaos, it's Mrs. Thompson, whose magnesium is 1.2, but she's, quote, not having any symptoms.
Oh, hello, dears. I'm Miss Thompson, and I feel fine. My heart is doing a little flippy thing, but that's normal for me.
Mrs. Thompson, honey, that flippy thing is frequent ectopic beats, and your magnesium is 1.2. That is a symptom.
Well, I don't feel bad. Should I feel bad if something's wrong?
The premature atrial contractions on the monitor, Mrs. Thompson, right now, that is the symptom, ma'am.
But wait, there's more. Contestant number 3 is Mr. Rodriguez, who drank a gallon of water before his labs because he wanted them to be good.
Hey, I'm Mr. Rodriguez. I wanted my labs to be really good today, so I drank a whole gallon of water this morning. Smart, right? I figured if I'm super hydrated, everything will look great.
Sir, that's not how this works. That's not how any of this works. Now your sodium is 128, and we have to figure out if it's real or if you just diluted yourself into hyponatremia.
But I was trying to be healthy.
And our grand prize winner tonight is Miss Williams, who stopped taking her diuretics 3 days ago because her ankles looked fine, and now she's gained 15 pounds in fluid weight and can't breathe.
Oh, yes, hello. I'm Miss Williams. I stopped taking my water pills 3 days ago because my ankles looked just fine to me. They weren't even swollen. Well, now I'm up 15 pounds and I'm having a teensy bit of trouble breathing, but I'm sure it's not related.
Congratulations, Miss Williams. You've won an all-expense-paid trip to the cardiac unit, a lovely furosemide drip, and strict I&Os for the next 48 hours.
Tell her what else she's won, Chelsea.
An indwelling Foley catheter, because we need those accurate I's and O's.
Prizes also include daily weights at 0600, a low-sodium diet that you'll hate, compression stockings you can't put on yourself, and the privilege of being asked, "Are you short of breath?" 17 times per shift.
Wait, what? I don't understand, but I feel fine. I was just trying to be healthy.
Thanks for playing.
Guess that lab value. Remember, labs don't lie.
But patients sure do try to explain them away.
Tune in next week when we play, Is this potassium compatible with life? And how high can your glucose go?
Skills Lab Jesus, everybody, the man of 1,000 patient voices.
Hey, I just calls them like I hears them. And those are really real situations.
And that is both hilarious and terrifying.
Okay. Well, thank you for joining in on this episode of the Guess Your Electrolyte game show and the Serum Osmolality Hunger Games edition. So we're going to end it here, but come back for episode 2 of this subsection, and we will pick up on infusion therapies. Make it a great day, everyone.